Today we're exploring a detailed new report from the American College of Gastroenterology and the American Society for Gastrointestinal Endoscopy, published in the American Journal of Gastroenterology titled Quality Indicators for Colonoscopy. This report provides updated recommendations for gastroenterologists and endoscopy units, aiming to ensure every colonoscopy performed is a high quality procedure. So, why are we dedicating an entire episode to colonoscopy quality? Well, as many of you know, colonoscopy is the gold standard, the absolute cornerstone of colorectal cancer prevention. This procedure allows doctors to detect and remove precancerous polyps, effectively stopping cancer in its tracks. The article emphasizes the significant impact of a well executed colonoscopy in reducing both the occurrence and death rate from colorectal cancer. But here's the crucial point: not all colonoscopies are created equal. The effectiveness, how well it actually works in preventing cancer, hinges significantly on the skill and expertise of the physician performing it. And that's where quality indicators come into play. These indicators are like benchmarks, helping to standardize colonoscopy procedures across the board and ensure every patient receives the highest level of care possible. The ACG and ASGE task force emphasizes a set of priority quality indicators for colonoscopy, highlighting their crucial role in achieving the best possible outcomes for patients. These indicators are carefully selected based on several factors: their connection to important outcomes like cancer prevention, how easily they can be measured in real life clinical practice, evidence of inconsistencies in how they're applied, and expert consensus on their significance. Think of these as priority indicators as the non negotiables, the fundamental elements of a high quality colonoscopy. So let's break down these crucial indicators. First off is the adenoma detection rate, or the ADR. This is considered the most vital and validated quality measure in colonoscopy. It represents the percentage of patients over 45 undergoing a colonoscopy for screening, surveillance, or diagnosis who have at least one adenoma detected. An adenoma is defined as a type of polyp that is both precancerous and benign. It is benign today, but has potential to become a cancer in the future if not removed. A higher ADR signifies the doctor's proficiency in identifying these potentially cancerous growths. This update recommends a minimum ADR threshold of 35%, recognizing that the risk of colorectal cancer after a colonoscopy continues to decline as ADR increases, even exceeding 40%. Keep in mind this calculation excludes colonoscopies performed due to positive findings from other screening methods, such as positive stool tests, to allow for a more consistent comparison across healthcare systems. We would expect an even higher ADR for those exams that have a preceding positive stool or blood test. Number two is the sessile serrated lesion detection rate. This indicator is a new addition to the priority list, focusing on a specific type of polyp called a sessile serrated lesion, or SSL. These lesions are notorious for being tricky to spot, so a good detection rate is a strong indication of a skilled and meticulous colonoscopist. The report recommends that a minimum detection rate for SSLs be a threshold of 6%, a figure expected to increase as detection techniques continue to improve. The emphasis on sessile serrated lesion detection rates underscores the importance of detecting this specific type of lesion in preventing colorectal cancer. Number three on the list is bowel preparation quality. We can't stress this enough. A clean colon is the foundation of a successful and effective colonoscopy. This indicator measures how effectively patients can achieve adequate bowel prep before their procedure. The report emphasizes the significant implications of inadequate preparation, increasing both costs and risks for the patients. Therefore, achieving a high rate of adequate bowel prep is paramount. Number four is withdrawal time. This is the amount of time it takes the gastroenterologist to examine the colon from the beginning, which is known as the cecum, working carefully all the way back until the scope is removed. Data shows that, unsurprisingly, the longer you take to examine the colon directly correlates to finding more polyps. The previous expectation was averaging a 6-minute withdrawal time, but the updated recommendation is to spend an average of 8 minutes on withdrawal and examination. Lastly, for the purposes of our review, we'll talk about the cecal intubation rate. This indicator evaluates how often the doctor can successfully navigate the colonoscope through the entire colon all the way to the cecum. While a high cecal intubation rate is undoubtedly important for a comprehensive exam, the report acknowledges that the majority of seasoned gastroenterologists consistently achieve and maintain rates exceeding recommendations. Consequently, continuous monitoring of the cecal intubation rate may not be the most efficient use of resources in these cases. Now, let's shift gears a bit and address another critical aspect of colonoscopy quality. What happens after the procedure? The ACG and ASGE task force stresses the significance of appropriate post colonoscopy surveillance, particularly for patients with inflammatory bowel disease, a group at a higher risk of developing colorectal cancer. For these individuals, the report advocates for regular surveillance colonoscopies and emphasizes the importance of adhering to recommended surveillance intervals based on individual risk factors. These recommendations are based on the latest research and aim to optimize early detection and management of any potential issues. We've covered a lot of ground, but let's take a moment to recap the key takeaways from this ACG ASGE report. It's essential to understand that these quality indicators are not merely check marks on a to do list. Their primary purpose is to drive continuous improvement in colonoscopy practices, ultimately leading to better outcomes for patients. They empower both physicians and endoscopy units to identify areas for improvement and implement changes that enhance the quality and effectiveness of colonoscopies. The report strongly encourages physicians to regularly assess their performance based on these indicators and actively seek ways to improve in areas where they fall short. They recommend numerous strategies for enhancing colonoscopy quality, including adopting new technologies like high definition endoscopes and artificial intelligence systems, refining withdrawal techniques, and improving bowel preparation methods. Ultimately, the success of a colonoscopy hinges on a collaborative effort between the physician and the patient. Achieving adequate bowel preparation, for instance, requires patients to diligently follow pre procedure instructions. Open communication, shared understanding of the procedure, and a mutual commitment to quality between doctors and patients are paramount for achieving the best possible outcomes. Colonoscopy plays a crucial role in the fight against colorectal cancer, and these quality indicators help ensure this procedure lives up to its life saving potential. If you're due for a colonoscopy, don't delay and be sure to discuss these quality indicators with your doctor. Remember, knowledge is power, and in this case, it could also be life saving.